Hello, everyone. I'm Lillian Cao, President of Ifso, and I would like to extend a warm welcome to all of you who have logged on to the Ifso Journal Club for March 2021. Today celebrates the 25th Ifso Journal Club session, and we are very privileged to have the two leading co-authors of a recent publication in The Lancet. This landmark publication reports on the 10-year follow-up of a randomized clinical trial that Professor Francesco Rubino and Professor Geltrudi Mingroni conceived and designed. What is remarkable about this RCT is that the 10-year results support the benefits of metabolic surgery. The clinical impact of surgery is so dramatic that a sample size study with 60 patients was able to document a clear and statistically significant difference in the incidence of diabetes-related complications. Now, this is a remarkable study documenting evidence that type 2 diabetes is curable, even when the disease is neither mild nor of recent onset. So, ladies and gentlemen, friends and colleagues, you're about to listen to the evidence that surgery can achieve a cure for diabetes. I'd like to welcome firstly our two speakers and the two leading co-authors of this study. Firstly, Professor Geltrudi Mingroni from the Catholic University at Sacro Cuore in Rome, Italy. Professor Francesco Rubino, Chair of the Metabolic and Bariatric Surgery at the King's College London in the UK, and is also the member of the Ifso Scientific Committee. So welcome, Geltrudi and Francesco. We are also very privileged to have our two expert panelists join us for this Journal Club discussion. Firstly, Professor Akhtar Hussein from Norway. He's from the Nord University and his interests on diabetes and metabolic syndromes. And he's also the president-elect of the International Diabetes Federation. Professor John Wilding, head of the clinical research into obesity, diabetes, and endocrinology at the University of Liverpool, and he's the president of the World Obesity Federation. So a very warm welcome and thank you to both Professor Hussein and Professor Wilding for joining us. Now, before we start the presentation, I'd like the audience to participate in a couple of poll questions. So these questions will be repeated after the presentations. So the first poll question is type 2 diabetes a curable disease? So I'd like you to select one of the following. Yes, no, I don't know. So please put in your answers to this question now. So is type 2 diabetes a curable disease? Great, so 69% of you believe that it is. Thank you for that poll. I have a second poll to ask you to do before the presentation. And the question here is, Roux-en-Y gastric bypass and BPD have weight-independent effects on type 2 diabetes. Do you agree? Select one of the following, yes, no, or I don't know. Please put in your poll question answers now. So do you believe that RY, gastric bypass, and the BPD have weight-independent effects on type 2 diabetes? And again, 87% of you believe it is so. Well, thank you for your response. Well, ladies and gentlemen, this is the reason we are here for this Ifso Journal Club. So let's start the presentations.
Ladies and gentlemen, dear colleagues, it's my great pleasure to have this opportunity to show you the results of our recent paper published in The Lancet last January regarding the effects at 10-year follow-up of metabolic surgery versus conventional medical treatment to cure type 2 patients with type 2 diabetes. This is the consort flow diagram showing that we assessed for eligibility 72 patients, 12 of whom were excluded because they didn't meet inclusion criteria or declined to participate or for geographical distance. Then we allocated by randomizing the patients 1:1:1 to medical treatment plus lifestyle modification or biliopancreatic diversion or Roux-en-Y gastric bypass. At 10-year follow-up, we lost 2 patients in the medical arm because they early declined to participate. We had 1 patient who died of massive myocardial infarction at 5-year follow-up, and 2 patients discontinued the intervention because they crossed over 1 to biliopancreatic diversion and 1 to gastric bypass. Overall, at 10-year follow-up, we could analyze with the intention to treat analysis 18 patients in the medical arm, and the entire sample saw 20 and 20 patients in the BPD and in the gastric bypass arms. As you can see in the upper panel of the figure, the probability of being free of diabetes was almost 100% at 2 years, then gradually declined over time, reaching a plateau at 6-year follow-up, and at 10-year follow-up, therefore, 50% of the patients in the BPD arm were still free of diabetes, and also 25% of the patients in the gastric bypass arm were under diabetes remission. In the middle panel of the figure, you can see the time course of the glycated hemoglobin. At 1 and 2-year follow-up, we had a dramatic reduction of glycated hemoglobin levels, in particular after biliopancreatic diversion, but also after gastric bypass. And then gradually, there was an increase in glycated hemoglobin levels, so that at 10-year follow-up, these levels were around 6.5. But in any case, lower than the threshold of 7%, which is considered by ADA and ESD as an optimal glycemic control. You can also see that the patients under medical therapy had, however, a good glycemic compensation with an average level of glycated hemoglobin or 7.5%. Regarding the weight loss, we had a dramatic weight reduction in the first 2 years of follow-up after gastrointestinal surgery, followed by a slow but continuous increment of weight, so that at 10-year follow-up, however, all the patients had a 30% weight reduction from baseline. It is of interest, however, to notice that also the patients in the medical arm had a 5% weight reduction, which continued over time, which is unusual for patients doing only medical treatment and lifestyle modification, having a weight reduction over time. Concerning the quality of life, you can see that the quality of life was significantly better for both surgical arms as compared with the red area, which refers to the medical therapy. However, physical role, vitality, and mental health was significantly better in the patients who underwent gastric bypass as compared with biliopancreatic diversion. The 10-year diabetes-related complications were only 5% in the surgical arm, and were referred only to microvascular complications. In contrast, in the patients on medical therapy, 72% of the patients had diabetes-related complications, 11 referred to macrovascular complication, and 61 to microvascular complications. Regarding the treatment of diabetes, so the therapy, the patients under medical therapy alone, about in the 80% of the cases were under injectable drug treatment. So 53% were under insulin, 27% under GLP-1 receptor agonist plus oral hypoglycemic agents, and only 20% under anti-diabetic medications. In contrast, the patients who underwent gastric bypass, only in the 5% of the cases were using insulin, and 25% of them were still free of any anti-diabetic medications. Regarding the patients who underwent biliopancreatic diversion, 60% of them were free of treatment, any treatment for diabetes control. And only 5% were using GLP-1 receptor agonist plus oral hypoglycemic agents. So none of them was under injectable, insulin treatment. Therefore, we can conclude that the results of our study clearly show that surgery is more effective than medical treatment alone in the glycemic control in the long term in patients with type 2 diabetes. In addition, our study suggests that it's possible to reduce the frequency of monitoring of glycemia if the patients maintained at least for 5 years diabetes remission. However, larger studies are needed to confirm this finding. Also important is that clinicians and policymakers should receive these results, ensuring that metabolic surgery would be appropriately considered in the management of patients with obesity and type 2 diabetes. So thank you for your kind attention.
For the opportunity to present our study. Trude has already given you the outline of the results. The focus of my presentation will be to emphasize the limitations of the study, but also put the results in context and see what lessons could be learned. So here are my disclosures. So what are the limitations of the study? Now, the first and foremost is that this one was a single center randomized trial. So there are limitations in single center trials, of course, because they apply to a local population, because they apply to services that are provided by a limited number of physicians and surgeons, et cetera, and many others. And so, of course, this is one of the things we have to keep in mind. But of course, also another limitation is the open label structure of the study. Open label means that we investigators knew the allocation of patients to either surgery or medical therapy. Of course, it wasn't possible to blind patients to whether they had an operation or not, so the patients could not be blinded. But also we felt it was difficult to blind assessors because in the clinic, inevitably, you're going to see patients who had symptoms or evidence of having had an operation before. So we decided that it was better to be clean and clear about the open label structure. But of course, this is a theoretical drawback in terms of how outcomes are assessed. Of course, the other important limitation is the small sample size of the study, which means that every secondary endpoint of the study has to be considered with caution. Now we will think the findings are still robust, but of course caution is always important when the study is sized and powered for one outcome and not necessary for others. And that is particularly true all the time. That is particularly true when studies are smaller in size. Of course, this is important also for the choice of the procedure. The study was perhaps more designed for comparing surgery and medical therapy, but not necessarily powered to see the small but potentially important differences of different types in terms of in between procedures, even though we did find significant differences in for some of the outcomes. Another criticism that could be made to our study is that the choice of the primary endpoint, remission of diabetes, could be maybe one that could be controversial, because of course in theory this choice reduces the potential for medications to actually achieve that outcome. So that is theoretically true, because the definition of remission requires not being on medications. But I want to emphasize how why it's still important to have that outcome as a primary endpoint. The first one is because remission of diabetes was defined for the first time ever in 2009 by an ADA expert group. And so as a result, this definition was very strict. It required at least 1 year of not being on medical therapy and still maintaining normal glycemia to be able to claim remission. Now, in the past, bariatric surgery before this study and other studies that came after this definition were actually reported as having resolution of diabetes defined as having no medications or any other thing arbitrary, but really sometimes without even reference to the A1C levels or glycemic levels and whether or not medications were stopped for 3 months, 6 months, or beyond. So it's a very strict definition. And of course, with this definition, at the time the study was designed, there was no evidence whatsoever that a surgical operation could achieve that level of remission with that strict definition. And that was also, of course, applied to medications, lifestyle interventions. So what are the strengths of the study? Geltrude has already presented the fact that this is a small study, 60 patients, but at the end of 10 years, we had an overall 95% retention rate, which is quite remarkable. It's very difficult to maintain a retention rate of this level at such a long for such a long duration, but it's particularly difficult in surgical studies. You know that there's a lack of follow-up in many patients who have bariatric surgery. So this is particularly important, especially if you consider that if you look at the surgical groups, we have a 100% retention rate. So all the surgical patients were available for follow-up analysis at 10 years. So that's very important because it tells you enough. It's robust enough, the study is robust enough to look at the durability of remission in surgical patients. Now, whether remission was enforced one of the primary endpoint, I think the study still has strengths in the fact that there were predefined secondary endpoints that included various other measures of glycemic control beyond remission. So durability of remission, A1C below 7 as a target, change in A1C from baseline, medication usage, et cetera, et cetera. So all those things gives you a sense of the broader effect in terms of glycemic control that just beyond what remission tells you. And if you look, in fact, at the results, there is no question that the glycemic control after surgery was remarkably good, even in whether or not patients achieved remission or had relapse ultimately. So definitely, you can make a statement here, you can learn a lesson here that surgical treatment has a remarkable and dramatic effect in terms of glycemic control. That's particularly reinforced when you look at medications and the fact that before surgery there was significant medications, and after surgery, 10 years after, still most patients really use little or no medications to maintain excellent glycemic levels. That's also true for cardiovascular medications. All type of cardiovascular medications were dramatically reduced for the 10 years period. Another strength of the study I want to emphasize is that if you consider traditional bariatric surgery, patients who come forward are typically young female patients. They have a low prevalence of diabetes, usually around 30% of bariatric serious include patients with diabetes. It's mostly early onset diabetes and mild form of diabetes with low prevalence of insulin use. Now, we and others found that when you start operating patients with the intent to treat diabetes, these things change. In fact, patients tend to have more incidence, more prevalence of diabetes and more severe forms requiring more medications. Now, why this is important? This is important because previous series have shown that some of these aspects, including duration of diabetes and use of insulin, are negative predictors of remissions and potentially other outcomes. So when you operate on people for diabetes, you may actually operate on people who are a little bit different than the patients we have operated on for many years in bariatric surgery. So some of the historical reports from bariatric surgery may or may not apply to the true diabetes population with type 2 diabetes, which might be different than the population we see in traditional bariatric surgery. But I want to emphasize that in this study, the gender balance was much more physiologic, if you wish, reflecting the general population distribution of diabetes. Duration of diabetes was by design beyond more than 5 years, and on average 6 years. So it's a diabetes that's been there for a while. And there's all these patients had multiple medications, including insulin. They had an average of 2.5 medications, and many of them, 50% of them at baseline, were using insulin. So certainly not a early onset diabetes. This is a severe diabetes, and despite of that severity, I think it's remarkable that we have found that surgery could result in so low incidence of complications. I think the fact that diabetes was advanced enough is the reason why in the medical group, despite good glycemic control overall, we have seen a discrete number of complications, which makes the difference was observed between those groups. And I want to conclude by giving you the broader implications of the studies. I think we say that the study was not properly designed to define differences between BPD and Roux-en-Y gastric bypass. I want to emphasize that the BPD, first of all, that used in this study is not a duodenal switch variant, but it's actually the Scopinaro traditional classic BPD variant with a horizontal gastrectomy. So keep that in mind. Now, even though there was greater remission rates with BPD than bypass, so you can see, however, that in terms of glycemic control, when you look at overall A1C levels, the differences are not so dramatic anymore, and weight loss was similar, and quality of life was better with the Roux-en-Y gastric bypass. Remarkably importantly, I think BPD patients also had more nutritional complications of all types compared to people with Roux-en-Y gastric bypass. So even though the study has to be taken with caution in terms of comparing procedures, I think there is some lessons to be learned about the fact that perhaps gastric bypass is good enough and probably safer than BPD. So as a potential procedure of choices might have a better risk-benefit ratio. Now, relapse of diabetes is very important. What happens to people who relapse, who have relapsed after after remission? The first important thing is to say that interestingly, after 5 years of remission, the incidence of relapse becomes very, very minor. And so most people who achieve 5 to 6 year remission tend to maintain remission thereafter. I think that's a very important point. An important point also is to say, what happens to those who have relapsed? Do they go back to square one? Do they get worse diabetes control as they were at baseline? What we found was that all patients who experienced relapse of diabetes after remission maintained what everybody would consider a good control of glycemia, with an average A1C of 6.7. I think it's quite remarkable and instructive. So what's actually so important that it begs the question of whether we should or could consider reducing the frequency of glycemic monitoring and screening for complications in patients who have persistent remission for more than 5 years. Because if there is less likelihood of getting a relapse, but even if you have relapse, diabetes is normally quite well controlled with an A1C of 6.7. None of the patients who had relapse actually had any complications from diabetes. I think one has to entertain the idea that you could not necessarily stop monitoring. That's important, but potentially relax a bit the frequency. And I think that has implication for management, healthcare costs, et cetera, et cetera. Finally, two last things. One is the weight loss and diabetes. We found that weight changes did not predict diabetes remission nor relapse. Importantly, you can see that the level of patients with weight regain between those who had remission and those who had relapse is actually similar. So there is no difference in weight in those who have remission that persist and in those who have remission, relapse of diabetes after remission, suggesting overall at a clinical level that these operations may have weight-independent effects on diabetes. So on clinical outcomes, indeed, in this particular study with advanced diabetes, with 2 operations that have gastrointestinal bypass, there seems to be an effect on diabetes that goes beyond weight. And finally, the question about diabetes being a curable disease. Now, I don't take this question lightly. I think I've many years ago published this paper where I suggested that surgery could have a potential for curing diabetes, but I was very much focusing on the potential for cure. And I know that this is being controversial. I knew it would have been controversial, and I took tomatoes myself for actually proposing that idea. It's an idea that challenges long-held concepts that diabetes is progressive and irreversible, period. So I knew that suggesting otherwise would be controversial. And in fact, I didn't do that personally lightly. And I want to share with you one consideration. I had the venture of being interviewed at an important US TV show called 60 Minutes, where the anchor person, Leslie Stahl, asked me specifically whether surgery could cure diabetes. And she said, you can only answer yes or no. I said, well, I can't answer the question as a yes or no. And she went back and said, I'm sorry, you only have 2 options, and it's either yes or it's no. And I said, if I have to ask her to answer yes or no, then maybe I should say no. And why did I say that? And I said that because I thought we can't really claim cure of diabetes because we don't know what is the cause of diabetes. So how do you know that something is cured if you don't know whether you have removed the cause of diabetes? On the other hand, there is some potential for relapse. What happened then? So there's always a potential for relapse. So how can you be sure that this is really a disease that is cured? But on the other hand, over the years, and I think I want to conclude with this message, I have personally changed my mind, and I think maybe some others could consider doing the same. Why should we consider that diabetes cure is not a taboo? It's something we should talk about. Well, first of all, because the fact that we don't know the cause of diabetes doesn't mean that we cannot claim cure. There's many diseases for which we claim clinical cure, even though we have no biological proof of eradication. And this is true for cancer and some other diseases. Diabetes can relapse long term. So what? You have definitions in other fields as 5-year cure, recurrence, new disease. You have people who have a recurrence, people who could have a new disease after having one being cured. An example of curable yet recurring diseases included cancer, pneumonia, UTIs. We wouldn't say that you cannot cure certain cancer. You wouldn't say that you cannot cure certain pneumonias, even though these diseases could not necessarily completely be biologically eradicated, or they could recur. What matters is that the ADA in 2009 defined cure of diabetes as a persistent state of diabetes remission for at least 5-year duration. So I do believe that we have this data from non-randomized trials showing that up to 10, 12 years, you can have as many as 50% persistence of remission. But of course, this, as I said, this is a bariatric population. It's not a typical diabetes population. We have situations where anecdotally I've found in personal series of patients who have severe diabetes on insulin baseline that go on for 10 years having no diabetes. And now, to conclude, we have scientific evidence from a randomized clinical trial where 37% of patients maintain diabetes remission for 10 years in a population, as shown by the medical group, that by no chance will have remission otherwise. And I think this is an important finding. So if I had to finish by saying, if I were to be interviewed again, and I were asked the same question, can surgery be a cure of diabetes? I think, in all honesty, I would personally say yes. I think I can say yes today. I want to conclude by finishing to say that there is the study shows and overall that surgery causes durable disease remission, excellent long-term glycemic control, including in patients with relapse, reduction of cardiovascular risk, less medication usage, lower incidence of diabetes-related complications, greater weight loss, and better quality of life. Now, of course, with all the limitations I mentioned, I think these are remarkable findings that justify the conclusion that the Lancet has printed on their cover page that states metabolic surgery is now safely demonstrated as being more effective than conventional available medical therapy in the long-term control of type 2 diabetes. Thank you for your attention.
Thank you very much for the presentations. That was wonderful. And it was great to see that there was a 90%, 95% follow-up and 100% in your surgical group. Before we start our discussion, I'm going to ask the audience to do a repoll of the 2 questions that we did previously. So the first question is type 2 diabetes a curable disease? Yes, no, I don't know. Okay, let's see what the audience. Well, there is an increase from 69% to 88% now for a yes. We'll go to the second question. RY, gastric bypass, and BPD have weight-independent effects on type 2 diabetes. Please select one of the following: yes, no, or I don't know. And the yes is 92%. That's an increase again. So I think this is very convincing to the audience that perhaps, Francesco, we could be more dramatic in our answers when we say there's a yes to a cure for diabetes. To start the discussion, I'm going to ask the first question to the audience. Should we reduce glycemic monitoring screening for diabetes complications in patients with 5 years continued diabetes remission? Please answer yes, no, or I don't know. And while the audience is putting their poll in, perhaps I'll ask Professor Worlding to start a discussion.
Thanks very much, Lillian. Yes, I'm very happy to open the discussion. I must first congratulate Professor Mingroni and Professor Rubino for conducting such a fantastic study. I mean, I think people shouldn't underestimate how difficult it is to do a study, even a small single site study of this duration and with this high fidelity of follow-up. And the quality of the data is really fantastic. And I think this does really tell us something quite important about diabetes and how we should consider treating diabetes in people with severe obesity. I think, Professor Rubino, you touched on this in your presentation, but one of the first questions I have as a physician who sees people who've had bariatric surgery of different sorts is my slight concern about the BPD procedure. Clearly, this is a procedure that is very rarely done these days, and although the duodenal switch procedure is still done in some centres, it's not done that often. And the reasons why it's not done that often is because the long-term complications, nutritional and surgical, tend to be somewhat greater. And I think you suggested that you thought probably, although the results appeared slightly better for the BPD in terms of the diabetes outcomes, on balance, you'd probably say that wasn't worth the extra pain. Would you like to just expand on that a little bit?
Well, definitely. I think this is a very important question, especially speaking to a surgical audience about, procedure, which one you choose. I think the BPD is an extraordinary procedure. In terms of efficacy, it's extraordinary. But one of the things I want to emphasize is that we didn't find difference in weight loss between the two, but only because we operated on patients whose BMI was up to 50 and not above. I think if you operate on people with a BMI over 50, you would have the added benefit of BPD being more effective in terms of weight loss in those extreme BMI cases. The question is whether the already known, and the study confirms side effects of BPD could be worth the risk. And the fact is that when you look at diabetes control, yes, remission is probably better in patients with BPD than in bypass. But if you look at overall glycemic control, you could achieve excellent glycemic control, including remission with bypassing, and maybe at the expenses of minimal medications. I think on balance, one would probably prefer to avoid the risk of those significant complications and maybe consider ONY gastric bypass more risk-benefit profile. But that said, maybe Joel Trudes and others can weigh in on this. I think BPD is an extraordinarily interesting operation from a mechanistic standpoint because the efficacy of remission is remarkable. And why is that happening? Why this procedure has such an incredible effect? I think it's something that researchers should be interesting and curious about.
Yeah, if I can, I mean, I'm not a surgeon, so I would like in the future to see a treatment, a drug treatment of obesity and diabetes, type 2 diabetes, so efficient as metabolic surgery. And indeed, as Francesco pointed out before, the biliopancreatic diversion is an extraordinary procedure determining remission of diabetes and net improvement of insulin resistance. So what we should try to understand is how it works. And the difference between gastric bypass and biliopancreatic diversion is the exclusion of the jejunum, which means that the jejunum should play a major role in insulin resistance and type 2 diabetes. So it is interesting for me, particularly on the mechanistic point of view.
Could I just come back to both of you on that point, because there was a paper published earlier this year in the New England Journal that suggested that all of the glycemic benefits were of Roux-en-Y gastric bypass, at least, were actually due to weight loss, and actually nothing at all to do with any of these other mechanisms that have been proposed, including changes in incretin hormones, potential other hormones that we haven't yet discovered. I just wonder what your thoughts are on that discussion on the basis of those data.
I must say that I have published another paper with St. Klein in Cell Metabolism just at the end of 2019, so 1 year ago, more or less, comparing the effect of gastric bypass with biliopancreatic diversion. We did the study here at the Catholic University, and Sam made the analysis in the United States. So we demonstrated that BPD was more effective in improving insulin sensitivity, much more effective than gastric bypass, which means that there is a difference between these two types of surgery, and it was completely independent on weight loss, because by design, the two groups of patients should have lost 20% of the baseline weight. So weight, it was absolutely weight independent, the effect. So I wrote a letter asking how it's possible to show so different data in two papers using the same approach, methodological approach. And also Francesco had some questions regarding this paper.
We published a letter in comment to that in the New England just after the publication in August. We followed up with Ricardo Cohen and myself. Jill Ture had another paper, and other colleagues I've seen have criticized the study on a number of issues. So I would just pinpoint one or two, but there are many more. There are many issues in the studies that could explain why the study's interpretation is misleading. Well, one is that when you talk about the effects on diabetes of interventions, whatever they are, you should control for diabetes status at baseline, right? That goes without saying. So you should have two groups that have the same diabetes, and then you can compare whatever happens in between the two. If you fail to have equivalence at baseline, then of course nothing stands. And so if you look at that study, there was significant differences in terms of duration of diabetes between the two groups, and the medication usage and other things that suggest clinically you are dealing with different severity of diabetes, with the more severe form being in the surgical group than in the lifestyle intervention groups that they used for demonstrating weight dependence of the results. The other issue is biologically there were some hormones and other factors, including insulin levels, leptins, etc., that were suggestive of differences in the biology of the two groups. But more importantly, also the fact that out of the many outcomes they measured, they used insulin sensitivity in the liver as a surrogate measure of diabetes control, which is insulin sensitivity is important, but it's not the only thing that justifies diabetes. So they just decided to dismiss all the other outcomes, including gut hormones and brain chain amino acid and any other thing that contributes to glucose metabolism, all those things being different, but they say this is not important. So saying that the mechanism, and finally, I wanted to conclude that I think all these studies, including my own studies, to make a mea culpa, if I can, that are done to understand whether weight is a factor or not. I think all of these studies, including my own, have been biased by this misconception that weight loss is a mechanism, whereas weight loss is not a mechanism. Weight loss is an outcome itself. So weight loss is an outcome of changes in hormones. Weight loss is an outcome of changes in many other things, including insulin sensitivity. So when you compare outcomes to outcomes, I don't think you can infer about mechanism. You have to, say mechanism will be changes in gut hormones, changes in some molecular factors, etc. But the clinical outcomes, changing your weight or changing your glycemia, those are clinical outcomes, and symptoms they change. They could be correlated, but not as necessary as a cause and effect.
Yeah, thank you. I think this debate will run and run, and we could probably talk about it all day and still not come to a conclusion. So we probably should move on. Akhtar, I think you wanted to make a comment.
Yeah, may I just pop in and Rubino, Professor Rubino, and it's a fantastic. It's a very impressive study, and I agree with Professor Welding that I mean, to have a kind of 10 years follow-up. Those who has done the follow-up studies, they know how difficult it is to maintain this kind of follow-up rate that you had. I would like to ask you in the same line that in terms of the baseline characteristic, if you see your table 2, that you see that, for example, insulin resistance, you have not calculated the significance, and I'm pretty sure that if you calculate the significance, you will find significantly different. The insulin resistance was much higher in the medically treated group compared to the surgical groups, both the surgical groups, and also it's also the same for triglyceride. What would be your comment?
Do you want to answer, Francesco? Or, so I mean, triglycerides, since BPD is a malabsorptive operation, you have a net reduction of cholesterol, total cholesterol, and triglycerides. It's typical for patients who underwent BPD to have a sort of vegan feature, so they have a very low circulating lipids, and same for the OMIR, because we didn't study really all body insulin sensitivity using stable isotopes, but we used a surrogate measure, which is OMIR, using only glucose, fasting glucose and fasting insulin. So we found, however, that there was a net reduction of hepatic insulin resistance in patients who underwent gastrointestinal surgery as compared with medical treatment alone. And this can also justify partially the effect of surgery. Francesco, you want to comment?
Yeah, I think also the question was related to insulin resistance. I think the study has also shown that there was an improvement in insulin resistance in the patients who had remission, persistent remission, tended to have better insulin sensitivity, not surprisingly perhaps. But indeed, the ability to of surgery to improve insulin sensitivity seems to be relevant for remission. On the other hand, maybe some patients who have a more resilient form of insulin resistance might be less likely to maintain long-term remission. What causes insulin resistance, as you know, probably still very clear. And,
no, I agree. I'm just saying that probably there are something, but I'm also thinking from the perspective of the International Diabetes Federation, where we are thinking of the whole world, not one clinic or one country. And in that sense, we know that 50% of our people with diabetes, actually, they are not obese. They're non-obese population. And that brings back to your questions whether diabetes is curable. It's because whether the bariatric surgery can work is actually, we have seen that is those amongst the diabetes in those with morbid obese population. In your case, it was more than 35. In some studies, it was more than 40, and so on and so forth. So that brings to the discussions that whether we should be more careful to say that diabetes possibly is curable, in particular those with morbid obese population through bariatric surgery. And as you know that we have now, type 2 is not only one disease, now we have subcategorized into 4 different categories. So that brings us to that which type 2 that we are talking about. And if I follow the recent guidelines that is coming from the WHO, is probably the SIRD, or this insulin resistance and obesity group that you are actually talking about, not the other 3 groups. So we need to have some reservations whether we can say that we can cure yeah, this is my preliminary thoughts, but I would like to hear anyway that whether you agree or you have some other thoughts.
John, you were
yeah. I was just going to add a little bit to that, which I think maybe will help you in framing your discussion, because I think Akhtar makes a really good point about the different types of diabetes, and it makes me think a little bit of the RISE study, which you may be familiar with, which is a big prospective US study that has looked at different interventions in youth with type 2 diabetes. And one of those interventions was actually gastric banding, okay, not a Roux-en-Y gastric bypass, not as an effective procedure for diabetes probably than a Roux-en-Y gastric bypass. But their primary outcome was actually looking at insulin secretory capacity rather than insulin resistance. And they showed that those interventions that they used, which included dietary weight loss, gastric banding, and I think there was also an arm which used a GLP-1 receptor analog. None of those actually changed the progressive nature of the decline in beta cell function that occurs in young people with early onset type 2 diabetes. Now, that may well be a different condition where there is much more predominance of beta cell failure than we see in these somewhat older, more insulin resistance people with severe obesity. So I just wonder if you'd just like to comment on that sort of whole concept and the effect on insulin secretion as opposed to insulin resistance.
I mean, we have published some years ago 2 studies, one in BPD and another after gastric bypass, showing that there is a restoration of the first phase of insulin secretion, which is usually lost in patients with type 2 diabetes, which means that it is a reversible condition. So it's not a damage of the beta cell, but rather inhibition of the secretive capacity of beta cells, which means that even after many years of type 2 diabetes, at least as Akhtar told before, in patients with insulin resistance and older patients, not young people, there is a possibility to recover the insulin secretion capability of beta cells, which is important also because studying the mechanisms could allow to find drugs which are able to stimulate insulin secretion in these patients.
Yeah, and if I can add, I think the question about the reproducibility of these results on different populations is very important, because obviously you can say this is a single center study. The population is very homogeneous. So the answer to that question, however, is that in terms of potency of surgery on diabetes in other type of populations, this is not what the study was trying to address, but we do have data from Ifso can be here the witness of that, and that across, no matter in which country you use it, no matter on which population, on which ethnicity, etc., the potency, at least the short, we don't have 10 years data on everybody, but the potency immediately is actually very remarkably consistent. You mentioned specifically the lower BMI patients. One of the things that actually fascinated me before I wanted to even become a bariatric surgeon, and actually changed my mind just because of that, was the report ever since the 1925 and beyond, that people who have gastrointestinal operations, including people of normal weight, can have reversal, or now we call it remission of diabetes. Geltrude actually was a main investigator on a case of 2 twins who had a BMI of 21 or 20 something, 22, who many years ago, now probably 20, underwent biliopancreatic diversion for a different reason, because they had a chylomicronemia, but they also had type 2 diabetes. Their diabetes has disappeared and has stayed, I think, away for more than maybe 2 decades now. So those patients were BMI 20 something. There's plenty of reports from India, from Brazil and other countries where these operations have been used in low BMI patients with decent level of efficacy, I would say, more than decent. And finally, I want to say something about the curability. When I say curable, and I hope I emphasize that. I wasn't, even if I suggested diabetes is potentially curable 20 years ago, I say potential. I didn't want to, I hesitant to say potentially, And the reason was exactly what you say, because it's a very heterogeneous disorder. You can't say the whole diabetes can be cured. However, while I still feel more confident today that the data are supporting the potential for cure, I think it's also fair to say that even if you can't cure everybody, that's no reason not to call it a cure when it actually works as a cure. I mean, there is no question that we don't cure every patient with cancer, but some patients with cancer are cured, and we tell them, yes, you are cured. I think it's unfair even to patients. When you have somebody who has no signs and symptoms of diabetes whatsoever for 10 years, taking no medication and anything, not giving them the reward of saying clinically, you are in a situation that could be defined as a clinical cure. We use this for all other conditions, with all the uncertainty that science gives us for those conditions. I think diabetes should not be an outlier. I think it's important to recognize a cure when we see it and call it as it is, even though we need to definitely emphasize, as you did, that for some patients this cure might not happen just because their disease is more advanced or because it's a different type of a subtype that doesn't respond to surgery. But that doesn't mean it's not curable, at least in some.
Yeah, I agree. There are a couple of questions from the audience, I think. Did you want to ask those, Lillian, or shall I do that?
No, I could. One of the questions was that diabetic patients it's like the property of the diabetic-tricians. Why will they not indicate metabolic surgery?
I mean, I'm a diabetologist, I'm an endocrinologist, but I was fascinated by metabolic surgery. So not all diabetologists think in the same way. So it's...
Yeah, I agree. I think we probably have to, some of us, those of us who do refer patients for bariatric surgery, probably have to educate our colleagues.
Yeah. I also agree that bariatric surgery is definitely a way to go. So however, the discussions could be that who are the potential candidates to go for surgery. So that's a different thinking. And as you know that, for example, if you are thinking of the BPDs, so you know that if you think of a kind of global scenario, that will depend on the scale of the surgeon very much, and also the kind of hygienic conditions of the facilities that you have. And we know that there are some adverse outcome comes out of BPD because of this thing. So in that sense, for example, laparoscopy is more safer, even though we see that the effect of BPD is much better, as you have demonstrated. So, but that's the kind of discussion which procedure. But nobody, I don't think that any diabetologist would say today that is that's not the way to go. As a question that who should go, that is the question that we diabetologists we ask.
Yeah, there is. Let's pause and look at the result of our first poll. So 55% of people agree that we should reduce glycemic monitoring for diabetes complications with 5 years of continued diabetes remission. This brings me to the next question. Someone put up that Patel et al. Have shown that bile is important for glucose absorption via the sodium glucose cotransporter. With the exclusion of the entire jejunum in BPD, hence more bile reabsorption before the jejunum and less bile in the ileum, could this explain the difference in efficacy between the Roux-en-Y gastric bypass and the BPD?
I mean, if I can, in the study published with St. Klein in Cell Metabolism last year, we have shown that the glucose absorption using stable isotopes was not impaired after video pancreatic diversion, but was comparable with before the operation, which means that I don't believe that the question of SGLT1, the transporter of glucose in the small intestine, can be the primary, can explain completely the effect of biliopancreatic diversion.
I think I can add something about the glucose transport. It's becoming a very hot topic at the moment, as Gertrude said, when we think about glucose transporters, we think about something that takes the glucose from one place to another and transports from the gut lumen into the circulation. And so a pedestrian explanation of the glycemic effect of any surgery, BPD or bypass, could be that simply you don't absorb enough glucose from your lumen, and therefore you reduce glycemia into your circulation. In reality, it's much more nuanced than that. And what we're learning about glucose transporters is that they also work in other tissues, in the kidney, for instance. As we know, we use SGLT2 inhibitors to reduce glycemia by inhibiting glucose transport in the kidney. However, what we and others have started to find is that gastrointestinal operation, including short bypass, not just a BPD long one, can actually alter glucose transporters expression, not only in the gut itself, mechanically bypassing a portion of it, but also in terms of expression in the kidney, and data we haven't published yet, but we're about to publish, in the heart. So supposedly this change in glucose transporters may be having additional effect, not just on glycemia, but on other aspects of metabolism, because they do control other aspects of metabolism. So they could control mitochondrial functions and other things indirectly, and potentially justify why some of these operations, maybe for what matters, some of the drugs that inhibit glucose transport can have cardiovascular effects.
Thanks, okay, there is Francesco. Someone else. There is someone else who wanted to know what extent were the surgical patients followed up in your study because of the 0% dropout rate?
This can happen, I think, in Italy, in France, in the UK, because people are not moving for changing place or working. In the United States, it will be impossible, I think, virtually impossible. So we have so many patients, not only these patients, but the great majority of our patients are followed up in our center for 30 years. So
I think for somebody who has been working in different environments, I worked in Italy, in France, in America, and now in the UK, I have to say that some of the reason why this study was made feasible, it might be less feasible or easy, at least in other contexts, because of the nature of the healthcare system in Italy. The national healthcare system in Italy makes such that a lot of this diabetes follow-ups and screening and tests, etc., are part of regular standard of care, which might not be the case in other countries. So a study like this would have costed significantly more in another country. I was in America, a study like this would have costed millions and millions of dollars. It also might, as Gertrude say, because of changes in insurance over time and insurance coverage and people moving around, maybe you would be most likely to lose patients at long-term follow-up than we did in Italy. So that's a context that has to be considered when trying to reproduce a study.
Yeah, I think just to comment on that, I think we have to remember that the results that we see in clinical trials, especially where patients are really closely followed up, do tend to be a little bit better than what might be seen in the real world. And that's one reason why I personally would be a little bit cautious about saying you don't need to follow up patients after 5 years, because we know that diabetes complications can develop quite insidiously. And if people have already had diabetes for several years before they have their bariatric surgery, they may have already accumulated some risk of complications. I think we may be able to maybe reduce the frequency of eye screening and urine testing and creatinine measurement and all these sorts of things in those people, but probably not stop it altogether. And that's one reason why, as a diabetes specialist, I would prefer the term remission, which we also use in cancer, to cure, which we don't tend to use in cancer because we never are really sure that we've cured the person.
Yes,
No,
I think yes, Professor Rubino.
I agree. So it's fine.
And I think
agree.
we all can agree on that point. And I think his Professor Holding point is very correct that because these people had their diabetes for example, several years, as we said, there's certain duration, and then we follow them for another 10 years or 5 years. And then by this time, the progressive nature of beta cell failure and its related complications on metabolism, and also the other complications that arises with this time. So it will not be recommendable to say that you should altogether drop your consultations. Probably the frequencies, as you have rightly pointed, frequencies can be discussed, that how often. And it also depend on the patient to patient, depending on their age and other comorbidities.
If I can add to that, because I say that we could potentially reduce. We say that very specifically in the conclusions of the study that we think it should never stop monitoring or screening, but maybe relaxing frequency is not a trivial difference. I think in somebody who has who has no evidence of diabetes by any laboratory or clinical finding, who has been already 5 years. So you have 5 years to capture if there has been any complication that wasn't seen but was already subclinical at baseline. By 5 years, it probably would have emerged. So if you, by 5 years, you have no evidence of any symptom, any sign, any complications, maybe not dropping altogether, but maybe just relaxing a bit the frequency would have quite a significant impact on healthcare costs. And I think it should be contemplated as a possibility.
Yeah, I think we're probably in agreement on that, actually, Francesco, which is great. Surgeons and physicians are agreeing.
Who would have ever thought that?
That's a big achievement. There is one
Can I
other
ask?
question.
You asked first, Lillian. Yeah.
There's one other question that one of the audience would like to know from the presenters or the panelists on their opinion on the metabolic effects of a 1 anastomosis gastric bypass.
Somebody wants to take it, or I can give my own take on it. I think 1 anastomosis gastric bypass is for me similar to what I say about a BPD from a mechanistic and investigational research point of view. I find it a very fascinating intervention. I think I would have predicted, and I think the data suggests that you could have potentially more incidence of remission compared to a standard gastric bypass, because there's a longer bypass, which makes it a bit more something similar to the BPD, or at least in between bypass Roux-en-Y and BPD. And so, not surprisingly, perhaps some of the early data suggest a superior glycemic effects of the procedures. There are many other potential side effects, however, that makes it also more similar to the BPD than to the Roux-en-Y gastric bypass. And besides that, of course, there are other anatomical issues like bile reflux, etc., that could require some point revision. I think it's an interesting operation. I consider it personally still a bit on the late phase of the investigational phase, but it's definitely something to look at. But I wouldn't replace necessarily standard care Roux-en-Y bypass with it, but I think it's a very important player at the moment.
And someone also wants to know about another emerging procedure, the transit bipartition procedure. What's your opinion about that?
Yeah.
I mean, I'm not sure I have enough knowledge of this operation. Perhaps Francesco is.
Well, I think, again, it's an experimental procedure, and some groups have reported interesting outcomes from diabetes. There are other procedures like ileal interposition and others that have been attempted and with some interesting results. I have a personal take on not just on this particular procedure, but on many other experimental ones that are being investigated. The study we just presented show you that the effects on diabetes with standard operation is remarkable. I'm not sure that we have any concern about potency, that we need additional operations, new operations. I think what we should do, as Akhtar said before, is perhaps more look at who we should operate, who we should prioritize, how we can make a limited resource available to the people who need it the most. Inventing new procedures is always good, but I'm not sure that any of the experimental procedure we have today in the pipeline have either a biological rationale or a clinical evidence to support their superior efficacy to the ones we already have as standards of care. So I haven't seen something that really would be a game changer in terms of either efficacy or safety. So I would say, let's play with what we have and investigate as much as science we want to do. That's great. But I think we have standards of care that are excellent, safe, effective. There is enough surgery there that can be done.
Indeed, what is preventing doing a large randomized controlled trial, multi-center, is that for bariatric surgery there are no funds from pharmaceutical companies, so it's difficult to do a large RCT study.
Although there is the bi-band sleeve study, which has now recruited nearly 1,200 people randomized to bypass sleeve or band in the UK. So this can be done. That's been publicly funded.
Oh, it's great. I'm looking forward to see the results. It's a very important study.
Could I make one more comment? Oh, Lillian, go again. You go.
Now, there was another question about what is the value of the C-peptide pre-operatively in determining whether patients respond metabolically to their surgery.
I mean, C-peptide, at least in our study, in these patients, there was a very good insulin secretion. So it was efficient. Also because patients with severe insulin resistance, usually they have enough insulin secretion. So if you reduce the insulin resistance, you improve the glycemic control. So we didn't have any patient with beta cell failure in our cohort.
I mean, I would use this clinically to just make sure that you're not missing patients with late onset autoimmune diabetes who have been misdiagnosed as type 2 diabetes and who are on insulin, because we've been caught out a couple of times. So we actually do measure C-peptide in patients on insulin just to make sure that we really are dealing with type 2 diabetes and not something else.
No, what we do usually as standard of care in all our patients is not only to measure fasting C-peptide, but to do an oral glucose tolerance test to measure the time course of insulin secretion. We use modeling, mathematical modeling of insulin secretion to see if there is a first phase of insulin secretion, second phase of insulin secretion. So we model the whole insulin secretory capacity of the beta cells, and we do this in all patients. In our we have almost 3,000 patients per year, so we are doing a lot of insulin secretory studies.
John, if I can add to that, I think I personally I've done this test of all the patients systematically when they come to my observation. I test C-peptide, but also antibodies, Xxv antibodies. I did this in a even unfriendly insurance-wise environment, like when I was in America. I was always requesting those tests that are not standard of care. What I've learned, I can't really give data because unfortunately, as you know, the LADA and GAT65 is not as prevalent. Therefore, it's difficult to really tell with confidence whether or not they are negative predicting factors, at least in an individual single surgeon experience. But I do have the anecdotal experienced that positivity for GAT65 could potentially reduce the ability of surgery to induce complete remission. That doesn't mean, however, that the patient is not going to have a major benefit anyway in glucose. But I want to also underline, we published in Diabetes Care a few years ago some anecdotal cases of no response whatsoever to surgery. All these patients had a massive weight loss, like 50, 70% excess weight loss. Some of them had no LADA, no antibodies, no other reasons. They responded beautifully from a weight loss perspective. They were super, in the morbid obese range, so they were not low BMI or anything. So you would have expected diabetes to melt away, and they had very early diabetes. And they did not respond to surgery at all. So their A1C remained stable. So we say there are some patients that might have a refractory form of diabetes that is not captured by any of the laboratory tests we have today, including LADA, GAT65, etc. So we need to be aware that they exist. They're probably not so common, but they do exist, and I don't know how to classify them.
But you see, again,
We can't hear you, Akhtar.
do you hear me now?
Yeah.
You see that I always think in a different way, that I come from Bangladesh, and you know that the diabetic clinic that we have, that in that diabetic clinic is probably the largest in the whole world, that in a single day we see about 3,000 outdoor patients, not in a year, a single day. And then you can understand that how difficult it is to have the kind of control that you are talking about. So but going for phase 1, phase 2, it's an impossibility. And actually, as a consultant, you see about 100 patients a single day. So this is the reality that I think more than 80% of the people with diabetes faces. So we have to think in terms of misclassification. So yeah.
Yeah.
There is a question about why do we think that the control group had an improvement in glucose control over time, despite relatively low use of GLP-1 receptor agonists and so on? And I suppose that also begs a second question that I would have for you, which is, this study was designed probably a little bit more than 10 years ago, run over the last 10 years. In the last 10 years, we've seen GLP-1 analogs and SGLT2 inhibitors, both of which have significant independent effects on diabetes complications, including nephropathy, heart failure, heart disease. And so I would just argue the case here that perhaps the standard of care that was used in your study would not be the standard of care today, and that maybe we would see better results with modern treatment, particularly with the newer, very potent GLP-1 analogs like semaglutide and dulaglutide that give much greater weight loss than we see with older agents that were probably used in this study. So, I suppose the question is medical treatment catching up, and when do you think we'll get to the point where medical treatment is as good as surgery? I suspect we'll be there in 10 years.
I mean, in our study recently, we have intensified the use of GLP-1 receptor agonists plus SGLT2 inhibitors. And in my opinion, this is the reason why the patients lost some weight and maintained the weight lost. Otherwise, usually in the clinical trials, over time, the patients under lifestyle modification and medical treatment increase their weight. So I'm satisfied with the glycemic control and weight maintenance of the patients under medical treatment alone.
Yeah, if I can add to that, John, is I think you will agree that 4.5%, 4.6% weight loss at 10 years in a non-surgical group, it's quite remarkable, and it's beyond what has been reported in the past. And in fact, I do think it attests to the fact the potency of modern medications, because as you say, the newer GLP-1 agonists have been used over the course of the last half of this trial, explaining perhaps why the weight control has been so good, and also the glycemic control has been so good. So I think that is good, because it does provide a good comparator in this study for surgery. The medical group was having what would arguably be considered acceptable, actually very good results in both in terms of weight loss and glycemic control. The question of whether in the future drugs or the drugs we have today could replace surgery is also very important. I think as a surgeon, I still believe that if you could treat a disease without a surgical operation, that would be a no-brainer. So if you could do it as simply with one medication, one pill, no-brainer. If you could do it with 2 pills, starts to be still good, but less. But if you have to take many pills, and then one starts to, could argue that the post effectiveness and other, risk of side effects of medication could become problematic. Now, is there a medication at the moment that can induce as much weight loss as surgery, as much glycemic improvement as surgery, decrease in cardiovascular complications? You will see very soon a major mortality paper coming up that shows surgery mortality benefits. I don't know that there is a drug at this time that by itself would do that. So what I think would be important going forward is that the new drugs that are coming up I think they're very effective, the ones for weight loss, they should take care of a lot of the patients that today we are operating on, and that could do well with those medications. So we put them into medication treatment, and maybe what we should do is to use surgery for patients that could not do as well with medications, and that unfortunately, paradoxically today, we are almost never reaching out to with surgery. So that's where I think the next 10 years should go. Surgery being deployed to treat the people, the minority of people who are treated today, and that could actually have the best interest in having surgery, and then potentially start treating patients with medications, so where maybe the benefit, the gap with surgery becomes narrower and narrower.
I think we should have we'll go to the polls. We have a few more questions to ask our audience. Next question is: metabolic surgery is more effective than available medications and lifestyle interventions for the treatment of type 2 diabetes and obesity? Yes, definitely. Yes, but we need more evidence, or no? Let's see what the audience poll questions are. Please cast your votes. So yes, definitely, we have enough evidence, is what the audience believe. While we bring up the next question, anybody like to comment on that? You have been convincing to our audience tonight. Next question: metabolic surgery can reduce diabetes-related complications? Yes, probably, no. Please put your poll in. The audience certainly believe that metabolic surgery can reduce diabetes-related complication. Great, I think we've achieved a lot in this journal club. One last question: what is the most important benefit of metabolic surgery in patients with type 2 diabetes that make it a strategy preferable to conventional therapies? Select one of the following: for the remission of diabetes, major improvement of glycemic control beyond remission, reduction of cardiovascular risk, ability to reduce diabetes-related complications, improve quality of life? Please cast your vote. The most important benefit of metabolic surgery. I'll be divided here. 1/3 believe it's a remission of diabetes. Another third, major improvement in glycemic control. Another third, ability to reduce diabetes-related complications. That is an endpoint. Well, thank you for your responses, audience. Okay, we've got one more question. Do you think the results can be generalized beyond the population considered in this study? Yes, no, maybe. So this is a population in one hospital in Italy. So can these results be extrapolated to other countries, other races, other cohorts? Majority say yes. Well, that concludes our poll. Perhaps I'll ask each of our speaker and our panelists for a 1 to 2 sentence take-home message to our audience. May I start with you, Gertrude?
Yeah, I hope that in the future there will be much more collaboration between endocrinologists, internists, and surgeons, which is crucial to have very good results and help people.
Thank you. Francesco?
I echo this. I think for the past 20 years, I've seen an increase in collaboration with between non-surgeons and surgeons. So the data from the study show that there is an incredibly powerful tool for treating diabetes. That this tool, in some cases, can, in my opinion, cure the disease. In other cases, it can't, but in some cases, it does. And I think just that should be a message of hope for everybody, physicians, surgeons, and researchers, because we should start moving our targets from the idea of managing diabetes to the idea of curing diabetes. In the 21st century, our efforts should be aimed at curing diabetes. Now, it might not be feasible for all. It might not be, widespread, etc. But if the fact that it's possible for some, it means that diabetes is vulnerable. The enemy is vulnerable, and then we should intensify efforts at understanding how surgery works, because we could potentially do what John said before. Maybe we could come up with better drugs in the future, or integrate existing drugs as we learn more about how surgery works to achieve similar effect, or potentially in some at least a cure.
Right. And Hussein? You're muted, Hussein.
We certainly need more collaboration across the professional groups, for example, surgeons, diabetologists, endocrinologists, and also the other health professionals. So I see that there are some developments which we should be open. I think it's important that we are not blocked. We see that there are some improvements in surgical side, but there are also improvements in medical sides. As Professor John has already mentioned, that the new generation drugs are coming, and which could be actually bringing the same effect as we are seeing for example, for surgical benefits. So I think that there are improvements both from the surgical side, and which is a good news for we have one common enemy, as Professor Rubino has said, that is the diabetes, and we need to join forces in order to fight it. Whether it comes from the medical side or whether it comes from the surgical side, it's not important. Important that we can fight the enemy and we can help people who needs our assistance.
Last but not least, John Wilding.
Yeah, I think from a physician's perspective, I think we need to keep talking to our colleagues and encouraging them to consider the right patients to be put forward for consideration of surgery. And I totally agree with my colleagues that surgery is as well as being a very useful treatment for some people, it's also studying these mechanisms is really important, because at the end of the day, I think this is teaching us things that we just did not ever know about diabetes. So the results of the surgical studies are teaching us physicians about diabetes. The surgeons are teaching physicians about diabetes. I think that's fantastic, and I think that will help us learn how to treat diabetes more effectively in the future, which is probably where we're all wanting to end up. Thank you.
Right. Well, I really like to thank our two speakers, Geltrude Mingroni and Francesco Rubino, for presenting their study, a remarkable study. I'd like to thank Hussein Akhtar and John Wilding for being such great panelists. Thank you for your contribution. And ladies and gentlemen, this concludes our Ifso Journal Club session. Thank you for attending. Now, this session, of course, has been recorded and will be available for viewing in our virtual academy on the Ifso website. So thank you, everyone. Have a good day or a good night. And we'll see you again soon in our next Ifso Journal Club. Thank you again. Bye for now.
Bye. Bye.